So Rakesh seems like such a nice young man, but he's so misguided. We'll tell you what the truth is here. What approach to functional tricuspid regurgitation? Because now Rakesh, he was only talking about people who were right-handed, right, who were under 30 and had blonde hair. I think he made some sort of very narrow statements about it. So is tricuspid regurgitation functional? Because most of the things we're talking about is functional. We don't have to worry about carcinoid or those kind of things. We don't see that. This is functional regurgitation with mitral. And of course, we would rather see patients before they develop TR and blow out their right ventricle and so on like that. But when we do, when do we fix it and how do we fix it? And what lessons have we learned? Because we have learned lessons quite a lot. Patients who have TR have all this presentation, but they feel terrible. TR is a terrible thing to leave, and it's a terrible thing to live with, and they die. So this is the problem with Dr. Suri's argument, is even moderate TR makes you die, and it makes you feel bad. They feel terrible, and they die if you leave moderate TR. So remember that. You do not want to have moderate TR. And if I operate on you and you have moderate TR, you want me to get rid of it. And probably you want me to get rid of your mild TR as well. You don't want TR because you die if you have moderate TR. I could stop right there, actually, but I won't. So TR is currently ignored. You can see that we do about 5,000 tricuspid cases a year and 50,000 mitral cases. So we ignore TR. But 3/4 of the cases that have mitral disease come with annular shape change. So I don't know how Rakesh narrowed that down to just 2 people in the United States, because it really should be 3/4 of that 60,000 we're doing tricuspid valves on now, because they already have annular shape change, even though they haven't blown their ventricles out. We've learned lots of lessons about tricuspid anatomy, that the anatomy of functional TR is up and out to the corner, and it forms an ovoid egg as it expands. That drags the ventricle open. And we have to look for it pre-op. Don't look for it in the operating room. It's functional. Under anesthesia, it will all go away. 4+ becomes mild, and then you try to justify it to yourself that, oh, it's not that bad, it's just mild, I'll leave it. And as soon as the patient wakes up, it'll come back. So you have the choice of either actually fixing the tricuspid valve or keeping the patient asleep for the rest of his life. And in fact, if you're stuck in the operating room and you're under TE and under anesthesia, don't even look for TR. Turn the color off. Look for tricuspid annular diameter greater than 40, or pulmonary pressure, or a large right atrium. Something that tells you there is significant tricuspid regurgitation. The right atrium and the annulus dilate because of TR, not because something else magical happens. No baby space aliens have invaded that right atrium. It's because of TR. Just fix it. Turn the transducer to the right. TR does not go away by itself. This is Pat's series of 5,589 mitral cases that Pat did in a week at the Cleveland Clinic when he was there. And 16% had significant TR, and when they fixed the mitral regurgitation, half of them still had severe TR when they went home. It does not just go away. The problem is, as Rakesh has said, that the right ventricle changes, and even though you fix the mitral valve, the right ventricle has changes in it. The tricuspid valve cannot fix itself in the vast majority of cases. This is the big paper that tipped our hand, Gilles Dreyfus's paper, 311 patients. He put his fist through the mitral annulus and through the tricuspid annulus, and then eventually he figured out to measure the circumference of his fist. It was 70 millimeters, and that equals about 40 millimeters in diameter, or 2/3 of the mitral. The 30-day mortality of adding a tricuspid valve to the mitral was negligible. In fact, it was a lower operative mortality, but the return of significant tricuspid regurgitation at 2 years was 2% in the treated group and 48% in the untreated. Look at that. Half of the patients that you didn't fix the TR, if they had a dilated annulus, this was regardless of whether they had TR or not, had return of severe tricuspid regurgitation. And do it now, don't do it later. This is the highest operative mortality operation that we do in the STS database. The operative mortality of patients is upwards to 35% when we think it will magically go away. It won't. And if you try to take the patient back, of course, they wait. We don't reoperate on patients. Reoperation is a terrible indicator of whether a patient is doing well or not, because we don't want to reoperate on this patient. We just fixed their mitral valve a couple years ago. And so they're kept in cardiologist's office until their shoes can't fit in, their feet can't fit in their shoes, and they have to wear the boxes. Their liver is down in their pelvis, and then we take them back to the operating room when their INR is 5 and they die. It is the highest operative mortality. We presented a paper here looking at a match set, propensity match set of 63 patients, 42 who we did now, 21 who we had to do later, and the operative mortality doing it now prophylactically was 0%. Doing it later, even in our hands, was 15%. Those patients had an enormous amount of complications when we had to wait and do it later because they are so sick going to the operating room. Once you got them through the operation, their survival was the same, but you clipped off a whole bunch. So don't wait to do it later, because you'll only get that patient back when they're sick as dogs. Do it now when you're there. You will ignore tricuspid regurgitation at the patient's peril. Do it now, not later. And we've learned lessons about how to do it. Of course, we use annuloplasty rings now. We don't use a DeVega. Of course, ring has risk with it. We have to think of that. We can hit the AV node, we can dehiss, we can have hemolysis, we can get endocarditis, but those are very small incidents of occurrence. When we use a ring as opposed to a stitch, there's less TR and better survival in these patients. They survive better. This is Jose Navia's. The more rigid ring you use, the better off you are. So if you use a pericardial strip, it will not work as well as a flexible band, which will not work as well as a rigid tricuspid annuloplasty in preventing the recurrence of TR. And this is the study from Montreal. Freedom from recurrence was best, again, with rigid rings. The evidence is overwhelming in the literature. Use a rigid ring. Does the RV die? The RV does not die. There's this paper, which was the original one. There's 2 more in the literature. It's just like the same argument we had with the mitral valve and the LV, that the mitral regurgitation was some kind of crazy pop-off keeping the LV alive, and if we fixed the mitral valve, the LV would die. No. Same thing with the RV. The RV only gets better when you take away the extra load of tricuspid regurgitation. We looked at our sizing strategy. We take the same size we put on the mitral valve and we put it on the tricuspid valve. We don't worry about getting tricuspid stenosis. We remember college physics. It's not the pressure, but it's the flow going through the same size hole. We will not get tricuspid stenosis, even a 26 ring. If you go pi r squared, you're going to have a 4 or 5 centimeter square orifice. You will not get tricuspid stenosis. Now, this is Rakesh's paper. He said they did 700 patients, and if you look at that, only 1 patient required tricuspid reoperation. 1 patient required tricuspid reoperation. That is absolutely the worst way to tell whether patients are doing well or not. And you see the patients who had moderate MTR stayed having moderate TR for the rest of their lives. That means that they died more frequently. We can go back to that first slide. If you have moderate TR, you will feel terrible and you will die more. So there's a best evidence paper in the literature, 390 papers reviewed on the topic of tricuspid regurgitation. The best evidence shows that the patients who have less TR survive better, and that moderate TR causes an increase of death. Even mild TR probably does. And that these patients do better with a rigid ring treated. So what are the guidelines right now? Well, the guidelines, in the American guidelines, are going to be revised very soon, and they'll look sort of like the European guidelines, which basically says if you are there doing an operation, fix it if there's any TR, or if it's dilated greater than 40 millimeters. So ignore or repair the TR. What lessons have learned? TR is not important. It is very important. If you leave TR, the patients die at a higher frequency and they feel terrible. There's not much TR around. No, there's lots of TR around. Repair the mitral valve and the TR will go away. No. We don't know how to. Yes, we do. Use a rigid ring. It adds operative mortality to do a TVR. No. In the big series, it probably lowers the operative mortality because the patients behave better. The RV will die if I cap off the TR. No, that is just not true. We will get tricuspid stenosis. No. So tricuspid regurgitation, no. Don't ignore it. Just do it. Thank you.